Welcome. My name is Dr. Kumar. I'm a consultant pediatric neurologist and founding partner of CYP Neuro, which is an initiative to provide high-quality clinical and educational services in pediatric neurology. And today I'll be speaking to Dr. Anil Israni, who is a consultant pediatric neurologist, friend, and a fellow founding partner of CYP Neuro. Now, as an introduction, we're both experienced pediatric neurologists who are able to bring our combined wisdom and experience over many years in pediatric neurology to others, such as yourselves listening, who would like to improve your knowledge and practice and to learn from where we could have done things better. Now, in this first episode, we'll be talking today about a common reason for referral to pediatric neurologists and pediatricians, a child or young person with swollen appearance of the optic discs. Now, this finding can cause concern for doctors, other clinicians, and for families because we know there are benign and serious causes which can be associated with vision loss or life-threatening causes. We know the serious causes need to be identified and treated quickly to avoid adverse outcomes such as blindness. But we know most children do not have serious causes, so we don't want to subject them to unnecessary invasive investigations like lumbar puncture or general anaesthetic. So let's get some practical insights and clinical approach to this problem from Dr. Israni, who's well experienced with dealing with this common scenario. And we'll approach this from our perspective as non-ophthalmologists, covering some of the common pitfalls and how to avoid them for us non-ophthalmologists. So, thank you, Dr. Israni, for joining me today. Can you remind us what the optic discs actually are, and why have we chosen the topic name of the podcast today as approach to swollen appearance of optic discs instead of just approach to swollen optic discs or approach to papilledema?
Thank you for inviting me, Dr. Kumar. Essentially, the optic discs are the visible portion of the optic nerves that are visible in the back of the eyeball, and they are seen through the pupil using an ophthalmoscope or sometimes some kind of a special imaging. The optic discs contain the entry or exit of the optic nerve axons between the brain and the retina. It is thus a window into the brain for neurologists. It also contains blood vessels. It is in the shape of a disc, hence the name optic disc. The optic disc can become edematous or swollen in neurological conditions, eye diseases, as well as some systemic conditions. However, a swollen appearance of optic disc does not necessarily mean optic disc edema. There are many causes and entities that can give rise to such appearance. Some are ophthalmological or ocular in origin, others are neurological or systemic. It is therefore important for pediatricians and pediatric neurologists to have familiarity of these ophthalmic and neurosystemic conditions which can give rise to swollen appearance of optic discs. The term papilledema is reserved for true swollen optic discs or discs, which means unilateral or bilateral, due to raised intracranial pressure.
Okay, so that's swollen discs or swollen optic discs, but I also hear about blurred disc margins as well. Is that different or same as swollen appearance of the optic discs or papilledema?
It essentially refers to the same problem. We come across the term blurred disc margins being used interchangeably with swollen discs or papilledema or disc edema or sometimes papillitis. The margins of the optic disc become blurred when the optic disc appears swollen. But it is important to be precise because these terms are relatively specific.
Okay, so I think that's an important point you raised there about being specific, and this issue about communication and miscommunication between colleagues about swollen optic disc appearance is important, and we'll discuss ways how we can improve this communication as well. So, what are the other serious entities or conditions that can result in appearance of swollen optic discs?
The true edema of the optic disc due to raised intracranial pressure and its underlying causes, or related to causes other than raised intracranial pressure, sometimes referred to as papillitis, can both give rise to swollen appearance of the optic disc. Now, the causes of swelling of the optic disc other than raised intracranial pressure can have a myriad of causes, including inflammatory and demyelinating, for example, optic neuritis, examples being anti-MOG or anti-aquaporin 4 related demyelination, infectious causes like Lyme's disease, infiltrative causes like leukemic infiltration of the optic nerve, ischemia and hypertension, which are common causes of ischemic optic neuropathy in adults, toxic drug induced and nutritional causes, compression of the optic nerve due to intraorbital masses, as well as some genetic conditions, for example, Leber's hereditary optic neuropathy. So, these are some of the non raised intracranial pressure related causes of swollen appearance of optic disc. The entities that cause edema of the optic disc can also cause a more posterior retrobulbar optic neuritis or dysfunction, and these might not show any obvious fundus or disc abnormalities on the ophthalmoscope, but these may be visible on special imaging.
Okay, so you've listed there some of the potentially serious causes that we need to think about and not just leap immediately to thinking about raised intracranial pressure. But before we get into the discussion about serious causes, what are the more common causes for that appearance of a swollen optic disc or a blurred disc margin? Maybe less serious.
As happens with most medical conditions, there are more benign mimics of the swollen appearance of optic discs, and they are most commonly congenital anatomical variants of the optic disc that may give rise to an appearance of swollen discs. We refer to these variants under one umbrella term of pseudopapilledema. And some of the examples of these variants are a congenital small disc, crowded optic disc, or when the eyeball axis is short, as in hypermetropia or tilted optic disc. A variant of fundus called Bergmester's papilla, where there is a tissue that emanates from the optic disc and may give rise to swollen appearance, as well as hypermyelinated retinal nerve fibers. Another peculiar variant, which is quite common, is called the optic nerve head drusen, which basically represents colloid proteinaceous deposit in the retina that mimics papilledema. It's quite common. Occasionally, it can be calcified, but that's not typically seen in younger children. At times, they are buried under the optic nerve head, so not immediately visible on fundoscopy. This is also typical in children. So you can imagine that drusen will be more difficult to distinguish from papilledema in children, especially the buried drusen.
Okay, so what you're saying essentially, fundamentally, is that a swollen appearing optic disc might not actually be swollen at all. And why is this important to know?
Yes, that's absolutely correct that appearances can sometimes be deceptive, and that becomes the crux of the matter. When we as pediatric neurologists get asked to see a child with swollen optic disc, we need to first stop and ask, are we dealing with a truly swollen optic disc, or is it pseudopapilledema? If it is swollen, is the swelling due to raised intracranial pressure, that is papilledema, or is the optic disc swelling due to other causes, the ophthalmological and the systemic causes we talked about earlier? Distinguishing papilledema from its mimic can help prevent a lot of unnecessary investigations, but also treat important alternative conditions. In fact, the majority of the children referred to us for swollen optic discs or papilledema from the community don't eventually turn out to have this following the assessment.
Yes, I mean, that's a very important point, and there is some emerging literature around this point. So, for example, I found a very interesting abstract from a UK conference a number of years ago, which was essentially an audit of children who'd been referred with concern of swollen optic discs, mostly from community optometrists in the UK to the paediatric services at a single tertiary hospital. And in that study, of the 42 children who were referred with concern of suspicious optic discs, only 2 children turned out to have a true intracranial pathology, which was an astrocytoma in one case and idiopathic intracranial hypertension in another case. And I think that this set of referrals ended up happening after a high-profile criminal court case in the UK, where an optometrist was found guilty of gross negligence manslaughter for not identifying swollen optic discs in a child where it turned out to be papilledema due to a brain tumour. In essence, as I say, the learning point is that it's very rare for swollen appearance of optic discs, or uncommon, I should say, swollen appearance of the optic discs to turn out to have a serious cause. There's also been a very recent article published in a journal aimed more at optometrists, which is from the Brisbane Hospital, and they identified in a series of 410 children referred for optic disc swelling that the most common etiology of optic disc swelling, when it was true, was idiopathic intracranial hypertension, but the great majority, something like 239 children, had pseudopapilledema due to optic disc drusen. So logically, given that the majority of cases with concern of optic disc swelling do not actually have true papilledema, what's the first step in the assessment to establish if the swollen appearance is true or due to a mimic? How do we go about this?
For a clinical neurologist, the clinical context is as much or probably more relevant than just the appearance of optic discs. Concluding raised intracranial pressure to be present based merely on swollen appearance of optic discs is a potential pitfall. And we need to go back to the basics of obtaining relevant clinical history with mapping of clinical onset and the trajectory, and establishing presence or absence of symptoms related to raised intracranial pressure, particularly recent onset of progressive headache, headache associated with Valsalva maneuvers, with worsening on sneezing, coughing, lying down, or bending forwards, presence of other red flags related to headache symptomatology like nocturnal waking or morning headache, neck pain or back pain, vomiting, pulsatile tinnitus, visual blurring, eye pain, transient visual obscurations, double vision, any systemic risk factors, medication history, as well as family history. The relevant points on general physical examination would be body weight and BMI, blood pressure, and relevant findings on neurological examination would be head size and shape, presence of any craniofacial dysmorphism, sutural ridging, presence of any cranial nerve deficit, especially abducens nerve palsy, other features of raised intracranial pressure, any focal neurological deficits, and any signs of meningeal irritation. In an office setting, a pediatric neurologist can perform some basic assessment related to ophthalmology, for example, visual acuity using Snellen's chart, color vision using Ishihara charts, assessing eye movements for any paralytic squint, gross visual field assessment using confrontation method. Of course, we need child's cooperation for that, and fundus examination using an ophthalmoscope. There are limitations to what information can be obtained from a toddler or young child, both with regards to clinical history and clinical examination due to issues with cooperation.
Okay, so what you're saying is that it is essential that the fundus findings need to be interpreted in the relevant clinical context. And so the clinical history needs to be focused on headaches, visual function, and some of the discriminative features of a serious versus not serious causes. And the physical examination needs to be focused on the features of a raised intracranial pressure or other serious causes. And importantly, you point out that in young children or children with intellectual disability, the history and examination is less reliable, so you need a higher index of suspicion for a serious cause. Now, we rely a lot on the ophthalmologist's eye assessment, and often they've seen the child before us. So what do you think is the ophthalmologist's role in assessing these children?
An experienced ophthalmologist, especially a neuro-ophthalmologist, can, based on skill and experience, reliably differentiate between various entities giving rise to swollen appearance of optic discs. There may be spontaneous venous pulsation present, and when so, a papilledema is not present or probably is very early. Or the blurred disc margins may be incomplete or in atypical areas such as temporal rather than classically nasal, or there may be retinal peripapillary hemorrhages that are not common in causes other than raised intracranial pressure or true papilledema. In optic neuritis, color vision may be affected early and the eye movements tend to be painful often, whereas loss of visual acuity is not typical early in papilledema unless there is macular edema and eye pain is often absent. There may be eye movement abnormalities in either condition due to the false localizing feature of sixth nerve palsy or internuclear ophthalmoplegia. Ophthalmologists tend to dilate the pupils with mydriatics for examination, although there's no difficulty in principle for such to be done by non-ophthalmologists. However, eye examination in children can be challenging even for experienced ophthalmologists. Not all ophthalmologists will be aware of the range of differential diagnosis that we discussed earlier and the discriminative value of clinical history and examination features. However, there are some additional ancillary tests that can be helpful, especially when there are overlapping features on ophthalmoscopy between papilledema and pseudopapilledema.
Okay, so you've mentioned some ancillary investigations. So we want to obviously get to the underlying cause efficiently and in a timely way without unnecessarily subjecting the majority of children who we already know may not have a serious underlying cause. We don't want to subject them to invasive tests or general anaesthetic. So what would be your approach in terms of the ancillary investigations?
Yeah, much will depend on local availability and expertise. Ultrasound B scan of the orbit is a very useful, simple, non invasive outpatient based test performed by radiologists and in some centers by ophthalmologists themselves. This can help pick up an optic nerve head drusen, especially if it is calcified. It can also show dilatation of the optic nerve sheath and raised optic nerve heads. It can show as a hyperechoic nodule beneath the optic nerve head at low gain level. And in the presence of acquired dysedema, the B scan will demonstrate a circle within the optic nerve sheath, separating the sheath from the optic nerve at a standard gain level. This is called a crescent sign, and this is produced by the increased cerebral spinal fluid transmitted along the subdural space within the optic nerve. The other investigation is called OCT, which stands for optical coherence tomography. This can help differentiate papilledema from optic nerve head drusen, as well as is useful in treatment monitoring in a number of neuro-ophthalmological conditions. It's an outpatient based test but needs special high cost equipment run by ophthalmologists. What it does is it measures retinal nerve fiber layer thickness and it can be considered a window into the brains since it is correlated with CNS nerve axon integrity. After all, that is what papilledema actually is. It's edema due to optic nerve axon dysfunction. And retinal nerve fiber layer thickness is usually high in papilledema, at least early untreated ones, whereas thinned out in drusen. Characteristic shadows and lumps may be visible in drusen. Aside from fundus photography, OCT can also be used to follow up cases of papilledema on treatment to look for resolution over time. What would happen is the retinal nerve layer thickness would slowly reduce back to baseline. However, the thinning can also represent chronic damage associated with optic disc atrophy. Another ancillary investigation is fluorescein angiography. It is invasive and involves injecting the dye intravenously and looking for dye leakage in true optic disc swelling. Fluorescein angiography can be helpful in papilledema, where the optic nerve head will show hyperfluorescence and peripapillary leakage of the dye. In congenital disc elevation, there is no such leakage, especially in the late phase. It is, however, an invasive test and needs cooperation of the child or young person.
Okay, so you've mentioned there the ultrasound B scan, ultrasound of the orbits, optical coherence tomography, and fluorescein angiography. Now, I particularly like the sound of optic nerve head ultrasound because it sounds like this is relatively cheap, portable, and the technology is advancing ever forwards in ultrasound. Now, this method is already being used in point of care by non-ophthalmologists. So I've seen articles discussing emergency medicine usage, B-scan ultrasound for identifying papilledema. And the article I mentioned earlier from the Brisbane hospital found that actually B-scan ultrasound was the most sensitive test for detection of optic disc grooves and outperforming optical coherence tomography as well. So that certainly is an area we should be looking at in the future. Now, continuing with ancillary investigations, what is the next set of investigations that we should use to narrow down the underlying diagnosis, particularly if we think it is true disc swelling after all?
Not only based on ophthalmoscopy findings, but also on clinical history and examination, where the index of suspicion of optic disc swelling being true, that is because of raised intracranial pressure, the imaging modality of choice is MRI of the brain with MR venography. This is to look for the most important causes of raised intracranial pressure, like any mass lesion, hydrocephalus, cerebral edema, and cerebral venous sinus thrombosis. And MRI of the orbits, particularly T1 with fat suppression, may also be relevant if there is vision impairment, eye movement restriction, or eye pain. MRI of the brain is also relevant to look at other causes of papillitis, disc swelling without raised intracranial pressure. In reality, the majority of children with disc swelling will require an MRI of the brain even when there are no signs of raised intracranial pressure, since alternative causes of papillitis often have CNS involvement, eyes being the extension of the brain. CT head is an acceptable modality in emergency situations, especially in the setting of head injury due to trauma and suspicious signs of progressively raised intracranial pressure or meningitis. However, when a mass lesion is suspected in posterior cranial fossa, MRI brain with MRV is the most appropriate imaging modality to undertake, since it is well recognized that CT head has limited sensitivity for posterior fossa lesions, which are relatively common in children compared to adults. Idiopathic intracranial hypertension will also not be identified or excluded on a CT scan. So, an MRI with MRV is important in this setting for two reasons. One, to exclude or look for any venous sinus thrombosis, and secondly, to see any suggestive features on MRI brain scan pointing towards IIH.
Okay. So to summarize, MRI brain and MR venous sequence, MRV, should be undertaken early in distinguishing the underlying etiology, where there is a high prior risk of underlying pathology based on the clinical history and symptoms examination that we've undertaken. And potentially we may need to think about MRI of the orbit based on the specifics of the eye-based findings. If there's visual acuity loss, then MRI and the MRV become urgent investigations rather than something to be done routinely from the outpatients. Now, in our usual practice as paediatric neurologists, we often receive referrals for children who have only had an MRI brain scan, sometimes requested by the ophthalmologist, and they've usually been undertaken without contrast or the MRV sequence. Now, I'm going to assume here that a significant mass lesion or anatomical finding like hydrocephalus will be detected on the standard MRI brain scan. But as we discussed earlier, the majority of children will not have abnormalities. So what clues are there for idiopathic intracranial hypertension being visible on a MRI brain before we get to having to do an invasive lumbar puncture study to confirm or identify raised pressure?
So, fundamentally, there are diagnostic criteria for IIH, which are based on radiological as well as lumbar puncture based CSF indices. So, radiologically, there must be an absence of a mass lesion, hydrocephalus, or any structural abnormality, as well as absence of cerebral venous sinus thrombosis on MRI of the brain with MR venography, because they can explain raised intracranial pressure. The second and third prerequisites are related to CSF indices. So that is based on an invasive test, obviously. The CSF constitution has to be normal, which means CNS inflammation like meningitis, encephalitis as the cause of raised ICP needs to be excluded. And thirdly, we need to objectively demonstrate raised intracranial pressure through measurement of CSF opening pressure by CSF manometry. We'll discuss the diagnosis of IIH and other related causes of raised intracranial pressure in a future episode since the situation is nuanced. Regarding the second question of what features can be seen on MRI of the brain that can suggest raised intracranial pressure in the context of IIH, these findings are not universally present, nor they are specific to raised intracranial pressure. So their absence would not exclude IIH, and their presence would not define the presence of IIH or other cause of ICP. The findings to look for are tortuosity of the optic nerves, dilated perioptic nerve sheaths, empty sella, posterior scleral flattening, protrusion of the optic nerve head into the orbit, and transverse sinus stenosis, particularly distal, although this will obviously need an MRV. A coronal contrast T1 can also demonstrate this finding.
Okay, so there are certainly some detailed findings on the MRI brain, if you know where to look, that would help, and with the MRV as well, in identifying clues to the presence of idiopathic intracranial hypertension. And this often needs discussion with an expert neuroradiologist. So we can already see how important it is to communicate between three specialties here already. So pediatric neurology or general pediatricians with an interest, the ophthalmologist and the neuroradiologist. And no one doctor or clinical specialist can be an expert in all three areas. Now, what other assessments should we undertake if we suspect that this is not papilledema due to raised intracranial pressure, but rather a papillitis of unknown cause? Remember, we may often leap to thinking about raised intracranial pressure, but there are some other important and potentially serious causes of the swollen disc appearance. Now, we'll only get to this when the MRI and lumbar puncture has been done, and they don't show any relevant findings to indicate that there is raised intracranial pressure, but nevertheless there are features of disc edema and perhaps some other equivocal symptoms and signs.
Absolutely. With CSF manometry, any pressure more than 28 centimeters of water is definitely raised intracranial pressure, and more than 25 centimeters of water is probably raised intracranial pressure. But other than papilledema due to raised intracranial pressure, there are other causes of papillitis which can produce swelling or edema of the optic disc. And these are a range of conditions from inflammatory demyelinating to infectious to toxic, infiltrative, ischemic, compressive, and even genetic. The investigations will be planned based on the clinical picture, a full blood count, UNEs, blood lactate, autoantibody profile, and when we are suspecting demyelination related optic neuritis, then anti-MOG or anti-aquaporin 4 related antibodies, CSF for PAD oligoclonal bands. Nutritional causes are reversible, so it would be important to look for any B12 deficiency, to look for retrobulbar optic neuritis and any optic pathway problems. VEP is helpful. To exclude any retinal level problems, ERG can be helpful. And when genetic condition like Leber's hereditary optic neuropathy is suspected, and relevant genetics need to be undertaken. We still need to consider a focus history and examination that would help us to distinguish between these differentials before weighing in with specific investigations. We need to look for potentially treatable and reversible causes of dysedema, and we need to prioritize them that will not progressively lead to irreversible vision loss or other systemic problems if left undiagnosed and untreated. Some of this will be outside our field of expertise as pediatric neurologists and pediatricians, but we should know the broad groups of diagnosis that we discussed earlier and the relevant screening investigations that will help us to identify a potentially reversible cause.
Okay, so you've noted already about the need to have a conjoint approach between ophthalmology, pediatrics or pediatric neurology and neuroradiology in deciding on the diagnostic approach and how quickly to act. Now, do you have any further tips on how to improve practice, getting to the diagnosis and treatment fast, but not over-investigating the majority of children who do not need the invasive investigations when there's a swollen appearance of the optic discs?
My experience is to talk to the ophthalmologist directly, sometimes even see the same child together in the clinic, chatting through the prior investigations, including the OCTs, the retinal photographs, and neuroimaging, correlating with symptoms and other signs. I think that is the best approach, particularly in gray cases. It's also useful to review the neuroimaging with the neuroradiologist rather than relying only on the report. Another important practice tip is to use standardized grading systems for describing optic disc swelling, particularly the Frisson grading system from 1 to 5. Learn visual examination techniques from an ophthalmologist, including use of ever improving technology such as handheld non mydriatic retinal camera and point of care wireless portable ultrasound. Learn more about common appearances of optic disc swelling from online publications and own experience. There may be a role for artificial intelligence algorithms based on automated retinal photographs and OCT analysis, although we are still in early stages of this technology.
Okay, so we'll now bring this podcast session to a close. Dr. Israni, what are your takeaway lessons for the paediatrician or practicing paediatric neurologist evaluating a child with a swollen appearance of the optic discs?
Thank you, Dr. Kumar, for your insightful questions and comments. I think the key takeaway lessons are there's no substitute for a meticulous clinical history and examination. Majority of asymptomatic children will not have true optic disc edema or papilledema. That there are other serious neurosystemic and eye conditions to identify other than causes of raised ICP. A normal MRI of the brain should not be the end of the assessment, or even a normal lumbar pressure, lumbar puncture, and CSF indices. That improving communication between ophthalmologists, neurologists, and neuroradiologists is essential in this situation. And there should be an MDT based approach towards these problems, especially the gray areas. And there is a lot to learn from each other amongst different specialties.
Okay, thank you very much, Dr. Israni, for joining me today in discussing this important topic. Now, this is just one of a series of podcasts, and we will share our experience with further childhood neurological conditions and scenarios in future podcasts. And we'll be returning to the theme of raised intracranial pressure and papilledema by interviewing other colleagues in ophthalmology, amongst other relevant specialists. Now, listeners can send in their questions and provide their comments and feedback via our LinkedIn pages or through the CYP Neuro website. On the website, we'll also share a transcript of this podcast episode and further references as we discussed on the CYP Neuro Academy web pages. Thank you very much once again.
Thank you.